Now we can look at more data of what happens in patients that have not residual cancer burden, but residual cancer cells and DNA. So with that, Dr. Milan Radovich is going to talk about detection of circulating tumor DNA after neoadjuvant chemotherapy. It's significantly associated with disease recurrence in early-stage triple-negative breast cancer, pre-planned correlative results from the clinical trial BRE-12158. Dr. Radovich is Associate Professor of Surgery and Medical and Molecular Genetics at Indiana University School of Medicine.
Well, good morning, and I'd like to personally thank the members of the media for being here bright and early this morning to hear these exciting results from the San Antonio Breast Cancer Symposium. And I'd like to also acknowledge my very good friend and colleague, Dr. Brian Schneider, a medical oncologist and professor of medicine who's the senior author of this study, who will also be available to answer questions after my presentation. So it's well known to this audience that triple-negative breast cancer, while it comprises a minority of breast cancers, about 15 to 20%, is a considerably more aggressive form of the disease. This is a disease that tends to affect women of African American descent and Hispanic descent, but also disproportionately affects women who are younger and also women who carry BRCA1 germline mutations. Unfortunately, women with triple-negative breast cancer have not benefited from the advances in hormonal and targeted therapy seen in other subtypes of breast cancer, and unfortunately, most are treated with just chemotherapy, radiation, and surgery. What we know with triple-negative breast cancer, unfortunately, is that these cancers tend to recur at a very high rate, particularly peaking in the first 3 years after surgery. And this unfortunately causes a very untenable situation for our patients who live in constant fear and uncertainty of their cancers recurring after chemotherapy and surgery. I would like to highlight Ms. Ginny Mason, a 25-year survivor of inflammatory triple-negative breast cancer who's sitting in the front row of the audience, who can speak to the media about the patient experience and the fear and uncertainty that occurs when patients have completed chemotherapy and surgery in fear of their cancers coming back. She's also the director of the Inflammatory Breast Cancer Research Foundation and can also speak to you about the advances in research for this aggressive disease. The current typical standard of care for triple-negative breast cancer in the early stages is for patients to be treated with neoadjuvant chemotherapy, typically with a 3-drug combo of adriamycin, Cytoxan, and Taxol, and then these patients go to surgery. As Dr. Simmons mentioned, about 1/3 will get a pathologic complete response, meaning the chemotherapy melted the entire tumor away, and these patients do really quite well. Their long-term survival is quite high. But unfortunately, 2/3 will have residual disease, meaning the chemotherapy did not melt all the tumor away. There's residual disease available at the time, that is present at the time of surgery, and these patients tend to have a very poor survival outcome. So in our study, we really focused on this residual disease population and harnessed the power of circulating tumor markers. The first marker we focused on was a marker called circulating tumor DNA, or ctDNA. And ctDNA is actually DNA that is shed from tumors into the circulation, such that one can use really powerful next-generation sequencing techniques to detect these tumor markers in the circulation in a very non-invasive manner. We also studied circulating tumor cells, or CTCs, and these are actually live tumor cells floating in the circulation where one can use, again, very sensitive techniques with a simple blood draw to detect the presence of these CTCs. And the question is, if we detect these ctDNA in CTCs in patients who have completed neoadjuvant chemotherapy and surgery, are they at high risk of their cancers coming back? Again, these patients after chemotherapy and surgery are quote-unquote disease-free. We don't detect any cancer, you can't feel it, you can't see it, you can't scan for it, but we know that a proportion of them, their cancers will come back. So for our analysis, we analyzed samples from our recently completed clinical trial, BRE-12158. And this trial was very innovative in that it took women with triple-negative breast cancer who underwent neoadjuvant chemotherapy and were determined to have significant residual disease at the time of surgery. On trial, their residual disease tumor was genomically sequenced, and patients were then randomized to either a genomically directed therapeutic or treatment of physician choice. The primary endpoint of this trial is 2-year disease-free survival, of which the primary endpoint is still currently maturing, and the results will be presented at a later date. For the studies that will be presented today, blood and plasma for both ctDNA and CTCs were collected at cycle 1, day 1 of patients enrolled on Arm A, and then at the first routine visit for patients enrolled on Arm B, and then followed for clinical outcomes. And here are the main results. The results are absolutely striking. patients who have ctDNA in their circulation after surgery have a significantly inferior distant disease-free survival compared to patients who are ctDNA negative. The estimated 2-year DDFS was 56% in patients who are ctDNA positive versus 81% in patients who are ctDNA negative, a highly significant p-value of 0.0055 with a hazard ratio of 2.99. We next looked also at the combination of ctDNA and CTCs. What happens when we combine these two powerful markers for circulating tumor material? And what we observed was a stepwise gradation in the outcomes shown here with distant disease-free survival. If patients were negative for both ctDNA and CTCs, they had an exceptionally superior outcome. If they were positive for one marker or the other, they had intermediate outcomes. And if they were positive for both ctDNA and CTCs, they had the worst inferior outcomes. When we compare, that skipped on me. All right. If we compare patients who are double positive versus double negative, the 2-year DDFS for patients who are double positive was 52%, and patients who are double negative was 89%, with a p-value of 0.0095 and a hazard ratio of 5.29. Now, to this point in my conversation, in my talk here, I've been pretty morbid. I've been telling you what are the markers that really point to patients who do poorly. But what I'd like to highlight here is the patients who do exceptionally well. This population that is both ctDNA negative and CTC negative had a 2-year DDFS of 89%, even though based on standard clinical parameters are at very high risk of relapse. When you analyze and look at their detailed clinical data, many of these patients had large tumors greater than 5 centimeters. Several had lymph node involvement, yet they were biomarker negative for both and have now had exceptional long-term outcomes. So in conclusion, patients with triple neg who have an incomplete response to neoadjuvant chemotherapy can be further risk stratified based on the presence of MRD with technologies such as ctDNA. The addition of CTCs adds complementary information to ctDNA detection, and as I mentioned, the absence of both these markers has a superior ability for predicting patients who have no relapse. And importantly, and as mentioned by one of the members of the press, the detection of ctDNA in early-stage TNBC after neoadjuvant chemotherapy is an independent predictor of disease recurrence and represents, we think, an important novel stratification factor for future post-neoadjuvant trials. So while I think it's important now that we have a technology that can tell us which patients do poorly, I think the more important thing now is we need to learn how to act. And so we are excited to announce the launch of our new trial, BRE-18334, also known as the Persevere Trial, which will open in the first half of 2020. This trial will enroll women with triple-negative breast cancer who have residual disease, but then will be stratified by the powerful information provided by molecular MRD. Patients who are positive for ctDNA based on actionable genomic markers either identified in the plasma or on the residual disease tumor will be assigned to one of 4 arms in an umbrella-style design based on the genomic alteration observed, including mutations in DNA repair, PI3K-AKT, and markers for immunotherapy, all with a backbone of capecitabine. Patients who are positive for ctDNA but lack one of the pre-specified actionable genomic markers will be assigned to an arm of standard of care with capecitabine or treatment of physician's choice. Patients, however, who are negative for ctDNA will be assigned to an arm of treatment of physician's choice, which can include no therapy or chemotherapy of choice at the physician's discretion. It goes without saying that we would like to deeply acknowledge our patients and families for their participation in the BRE-12158 trial and deeply indebted to the numerous co-investigators at 25 sites across the U.S. for their participation. And thank you for your attention as well.
I will take questions. One clarification point. So on the trial, half of the patients received standard of care treatment and the other half received some other therapy. So these results reflect patients that may have received different sorts of therapies.
Correct.
Charles Bankhead, MedPage Today. Do you have the breakdown for how many people were double negative, double positive, and intermediate?
Yeah, it is roughly about a quarter were double positive and about a quarter were double negative, roughly, in that range.
Do you think that these results are applicable to other types of breast cancer?
Absolutely. It is, triple negative is definitely unique, as I mentioned in my introduction, that these women do peak, have a rapid recurrence that peaks in the first 3 years. And so we think that these, having the ctDNA information is really important for these women who can aggressively recur. We know, conversely, with estrogen receptor positive disease, recurrences can happen 10 years or later. And how ctDNA can work in that particular setting is currently unknown. But in triple negative, we believe it's the most opportune place to test this type of technology.
Question for Dr. Kaklamani. Two of the groups. I'd like to know what your thoughts would be about how to proceed. The double negative and the intermediate ones. What would you do if you got those results on a patient?
Well, that's why we have clinical trials, and this is where I'm assuming did patients get told what the results were?
The ones in our previous study?
In this, yes.
In the study no, this was a pre-planned correlative analysis.
And that's the important thing. I don't like disclosing results to a patient where I can't act on them. Yeah. And that's very important. But that's why we need these, so that we can do clinical research, so that we can figure out, can we salvage these patients with our novel therapies? And maybe we can, maybe we can't.
I'm sorry, one last question. Sure. Do you consider one of these markers more informative than the other?
It's a great question. We know that ctDNA is considerably more sensitive than CTCs, but that, and I'll show it in the general session, but CTCs provide complementary information to help augment ctDNA, and when you combine both, the sensitivity to detect recurrence went from 79% with ctDNA alone to 90% when we combined with CTCs.
Wayne Kuznar, Onco Exchange.
Yeah.
You assess these markers at a single time point.
Yeah.
Would there be any value to doing these serially in the, any of those
Absolutely. When this trial was first designed, it was about 2014. ctDNA was in its infancy. And what we've learned since then is that serial sampling is absolutely essential to really increase your sensitivity and discriminatory capacity. And so, first of all, that first time point after surgery is probably the most clinically relevant, because that's where decisions are made. But in our subsequent study, we will be serially sampling to really look at the changes in dynamics in ctDNA while patients are on therapy and afterwards.
Yeah, this is such an exciting area, and I just wanted to say that this does apply to other types of breast cancer. There's a poster tonight at P501 the poster session tonight, P50104, that shows using a personalized ctDNA, and we did this in I-SPY. It actually really applies to everyone, at least with high risk, molecularly high risk disease. So I would agree with you. This is the future of how we're going to get people to the best outcome. Yeah.
Thank you.
I have one last question. This was done at the end of neoadjuvant therapy, right?
The draw was done after neoadjuvant chemotherapy and surgery. So patients were enrolled after surgery when they were determined to have residual disease. Okay. That was eligible for enrollment.
I think there's a question on the webcast.
Hi, yes, this question is for you, Dr. Kaklamani, from Kate O'Rourke. She asks, can you comment on whether the results from this trial should impact practice, and if so, how?
Would you like to?
They should impact clinical research for now. We don't have predictive data as to how we're going to act on this and improve patient outcomes. And so what we need is exactly the trial that the investigators have designed to see whether these results can then further help us in treating our patients and improving their outcomes.
Yeah, that's exactly right. So let me put it more simply. Should we be doing this on Monday in clinic? And the answer is no. What we don't know is if having this information is really going to improve outcomes, and will therapeutically intervening really improve outcomes for our patients. And as she just mentioned, trials like the Persevere trial that we just presented will be trials that we'll need to run to be asked that really important question.
MarisaWeissBreastCancer.org. How commonly available is this technology? And if you're a patient who hears about this, whose hospital doesn't perform this assay, can they send their slides to a facility that does it?
Yeah, so the technology is widely available, but I think what we are trying to really point out is that this technology is not really ready for this particular setting yet to be used in widespread clinical care. However, we do believe that this technology is really ready for prime time for post-neoadjuvant trials, and that all future trials really need to incorporate ctDNA as an important stratification factor.
And the important thing is it's not slides, it's actually blood. So it's very easy to collect, which is extremely important for our patients.
So the Hope Rugo, UCSF, in the thinking about patients and how this fits into the global scheme of things, if RCB actually, one, is associated with very good outcome, the correlation of this with your RCB score seems to be really critical in terms of helping our patients. Obviously, over time, these things occur, but we know that people have RCB1, they do well. So is that the group of patients who are negative for both? And then just for the audience as a whole, how do we design trials moving forward, keeping in mind what Marissa said and others? How do you tell a patient? So if you want to know how to impact outcome, you have to know the people who are positive and randomize them. How can patients be randomized if they know their outcome is bad?
So I'll answer the first part. I'm going to ask Dr. Schneider to answer the second part. For the first part of the question, I didn't show it here, but we'll show it in the general session, was all these analyses were actually multivariate analyses. So the markers were predictive of outcome even above tumor size, RCB, lymph node involvement, age, race, all typical clinical variables for patients with high-risk disease. So these are very powerful markers for a stratification factor.
So yeah, I think both some very provocative discussions today, both from Dr. Simmons and Dr. Radovich. And I think as we look forward to a better era of personalized medicine, I think all these tools can really help us better fine-tune. An important thing, though, is in BRE 12158, we actually did use RCB score. So, I think we can take a very close look at whether or not there is some interaction that may be synergistic.
Absolutely. And I will point out the vast majority of patients with RCB 2-3 that were enrolled on 12158.
So as a breast oncologist, I have another perspective. I mean, perhaps to get around this issue of what do you do with the people who have a good prognosis. The good prognosis doesn't sound too good to me. So if I was a 50-year-old woman and I have to tell her that she has 11% chance of having a fatal disease and dying before she reaches the age of 65, she wouldn't say that sounds so great, right? So basically, the concept could be, I mean, we do have things that we can give now for people who have residual disease, but the idea would be, can we get around that and redefine what good is? I mean, 10% is not good, if you're a 50-year-old woman. And I mean, it's better than it was.
Absolutely.
And you've identified a population that would have had a worse prognosis and now have a chance to have a better prognosis. But that may be another focus as we move forward, because we can now redefine what good is.
Thank you all for your comments. I know